This video is going to walk you through a number of genitourinary structures in the pelvis as well as in the abdomen, looking at some of the kidney stones and stuff of that nature. So we'll start out by looking at the normal female pelvis here. So you'll note that the uterus and bladder are going to be obviously in close approximation to each other. So here you can see the outline of the uterus as well as the bladder here more anteriorly. And so usually there's a little bit of peritoneal fat located in between, or pelvic fat rather, located in between the two, between the bladder and the uterus. So that's a good way to be able to make out the difference between the two. But keep in mind, it depends on the position of the bladder as well as the uterus and the positioning of the patient. So it's not always easy to be able to tell the difference between the two, but in general, that's the line that you're looking for to differentiate between the bladder and the uterus. So here we have an example of a male patient that is undergoing IVP. So in this case, there's been contrast injected into the bladder, and so now it's draining through the various parts of the urethra. So you can appreciate the prostatic part of it, the membranous part, and then eventually becoming the penile. You can see the bulbous urethra and then the penile urethra eventually more distally. Here we have an example of pathology. So this is a retrograde urethrogram. So again, contrast agent has been injected retrograde up through the ureter into the bladder. And so what we're trying to do is determine where, if anywhere, there is a breakdown in the ureter. And so you can see, again, the penile as well as the bulbous urethra, and then here we have the membranous and the prostatic urethra, and then this is the bladder located up here. And so what we're looking for is extravasation of contrast agent, which you can see is clearly occurring in the membranous urethra in this patient. So this is due to trauma in this patient, that they ruptured their membranous urethra. And so this is relatively common, especially with pelvic fractures. So car accidents, it's extremely common for there to be ruptured bladder and or a ruptured ureter, or urethra rather, in a car accident victim. So that's why it's always a good idea to go pee before you head out in your car. And so this just demonstrates where the extravasation occurred in that patient. So again, you can see the bulbous urethra down here, and then the membranous part just proximal to that. That's where the extravasation occurred. And then you have the prostatic urethra, which is sort of reinforced by the prostate. So in males, the membranous urethra is especially at risk for extravasation or for rupture. Now we're looking at a congenital condition known as, in this case, it's a bilateral ureteroceles that have been formed in this patient. So these are totally normal. Again, it's a congenital condition, but it doesn't cause any pathology, except it might actually make it easier to pass stones into the bladder, of course. But basically, there's just this distal dilation of the ureters right at the uretero-vesical junction, or the UVJ. And despite the fact that you have that dilation, it doesn't cause any significant issues for the patient. This is a typical Cub scan. So Cub scan stands for kidney, ureter, bladder. Basically, it's an abdominal radiograph, but it's historically been called a Cub scan, even though it allows you to look at virtually any structure within the abdominal pelvic cavity. And so just it's good to be aware of the fact that a Cub scan is basically an abdominal X-ray. And so with the Cub scan, obviously you're trying to appreciate the kidneys, the ureters, and then the bladder. So it's a good way to look for kidney stones. And you'll notice that the perirenal fat is going to make it somewhat easy to be able to appreciate the outlines of the kidneys. So in this patient, you can clearly make out the right kidney. Here's the liver right next to it. And then on the contralateral side, although you can make out the lateral border of the psoas major muscle, it's a little bit harder to make out a clear distinction or a clear border of the left kidney, but it looks like it's this structure right here. Although again, it's not the clearest view of it. The ureters are not visible, and again, unless you use contrast agent. But you do want to note that or recall, hopefully, that the kidneys are approximately over the T12 through L3 vertebral levels, which you can confirm that on this image by looking at the left kidney. So again, you go to the inferior border and count and look over. So again, you're looking at approximately the L3 vertebral level, L3, L4. So And then, you can go all the way up here and look at, here's your T12 vertebra right here. So again, you can see that 12th rib coming off. So here's L1, L2, L3, L4, L5. And so again, you can kind of confirm for yourself that is approximately the level of where the kidneys are located. And then remember that the ureters are going to be descending down along the anterior aspect of the transverse processes of L2 through 5. And then they're going to also pass anterior to the SI joint. So you should see them kind of coming across that SI joint. And then they're going to dump into the bladder posterolaterally. And in this patient, you might have noticed that there's this abnormality on the film. So evidently, this patient actually swallowed a pin or a needle. So you can kind of see the head of the needle and the tip of the needle up there. So now we're going to look at a normal IVP or an intravenous pyelogram. So in this case, what the procedure involves injecting a radiopaque dye, usually some sort of iodine-based dye, into one of the peripheral veins of the patient. And then eventually it's going to be excreted. That dye will be excreted through the kidneys. And so we take a series of scans or x-rays over the course of about 20 minutes, and that way we can monitor the progress of the dye as it's being excreted. So you'll be able to start seeing it show up in the renal calyces and the renal pelvis. Eventually you'll be able to make out the ureters and then ultimately the bladder. So when you think about where you need to be looking on one of these scans, you need to see the upper part of the renal poles, so about the T12 level. So here's T12 way up here, and then it needs to extend all the way down to just inferior to the pubic symphysis. And so it's oftentimes difficult to actually fit that entire area on a single radiograph. And so you might need to take another radiograph. And so before we move on to the next one, the next image here, you'll see in this one, there's a body piercing right here. So that's a belly button ring. And then you go down to the next one where, again, this is where we're trying to be able to visualize the lower part of the urinary tract. You'll notice that this patient also has another body piercing here. This is a clitoral ring on this female. So coming up and looking at the 1 minute time point here after the dye has been injected into the vein, you'll notice that we're starting to see the appearance of the renal calyces on each side. And then now at 5 minutes, you start seeing the renal pelvis quite clearly on both sides. You also can see now almost the entire, actually really you can see the entire ureter on the left and just the proximal part of the ureter on the right. And so again, now this is just a little bit later. So this is the 10-minute time point. So again, this was 5. Now we're looking at 10 minutes. And so you can see more of the right ureter and somewhat less of the left ureter. But you can see where the bladder has filled up relatively significantly with the radiopaque dye. And then now we have an oblique view. So here's the two ureters that, as you can see them descending down to the bladder, which you can appreciate down here. So again, this is going to be the right kidney and ureter, left kidney and ureter going down to the bladder. And then now this is just from the opposite side. So once again, now we can see the kidneys and the ureters descending down to the bladder down here in the pelvis. And then now we have a 20-minute scan. So this is 20 minutes after the initial injection of the dye. And you can see, you can still make out obviously the calyces and the pelvis, the ureters, a little bit on the left, better on the right. You can also see part of the ureter way down here along with the bladder right there. And then this is going to be immediately after voiding. So the patient went and peed, came back, took another image, and so now you can see where most of the dye has now been, you still have a little bit of residual dye, but the gross majority of what was in the bladder has now been voided. Here we have another example of an IVP. So this is just the initial scout film. And then now you can see this is the 10-minute time point, and you'll notice that this is an abnormal scout film or IVP scan. So on the right kidney, you'll hopefully notice that the renal pelvis is clearly dilated, as is the proximal part of the ureter, especially when you compare that to the left. You can see a good amount of the margin of the left kidney and virtually all of the right kidney in this patient. Now you can see the bladder, you can see obviously the entire left ureter, and then you can see a good amount of the right ureter, but you'll notice here where there's this dilation. So the kidney stone or the ureteral calculus is probably somewhere in this region, right about the location of the SI joint. So it looks like it's stuck here at this constriction point before it runs over the pelvic brim and down towards the bladder. So that's the approximate location of the blockage in this patient. And then here we have another view, and so you can see once again the blockage in the right kidney. So you can see it coming down, and then it has, you have this dilation, and then you don't see any distal evidence of the dye. So that's clearly what's going on there. But you'll also notice on the contralateral side, there's this sort of dark shadow that you see within the renal pelvis. And so this is what we call a filling defect. So that's usually evidence of one of two things, either a cyst on the kidney or possibly even a tumor of the kidney. So this is a CT cross-sectional view of a ureteral calculus. So again, a kidney stone located in the left ureter in this case. So note the organization of what that looks like. So I know we've talked about this before, but I just want to emphasize it again. The calculus itself is going to be hyperdense, especially if it's one of the radio-opaque type. So if it's a uric acid stone, it's not really going to be all that radio-opaque. It's going to be more radiolucent. So it'll be much more challenging to appreciate it on a conventional radiograph. But in this case, you can clearly make out the wall of the ureter, which is usually somewhat thicker than usual due to inflammation. Or it's edematous, so there's edema that's causing that wall to be thickened. And again, the central part of it then is going to be hyper intense due to the fact that the kidney stone is going to be blocking the X-ray beams just like a bone would. And here's just a table of the different types of or compositions of kidney stones. So you'll see that calcium oxalate is by far the most common type of stone. Hydroxyapatite is also relatively similar. So that's the same thing that bone's made out of, calcium phosphate. And you'll see down here uric acid, which is radiolucent. So that's the one that's really not going to appear very well. Cysteine is also relatively just, I would say, more mildly opaque. And so as a result, that can also be somewhat difficult to appreciate radiographically. And this is just for your own edification. This is showing you a chart of what can be done in terms of treatment management based on the location of a stone. So if the stone is located in the kidney, this is your option. So we'll start over here with the largest, the staghorn, greater than 2 centimeter stones. So usually this is going to require what's called percutaneous nephrolithotomy. So that's where there's a small incision made in the back, and we're able to then go in and surgically remove the kidney from whatever part of the kidney stone from whatever part of the kidney it's lodged in. Over here, if it's 1 or 2 centimeters in diameter, usually that's where we might use shockwave lithotomy. So that's where it's almost like ultrasound waves are used to help break down the stone. There's a couple other options. We could do percutaneous nephrolithotomy or ureterorhinoscopy. So that's just an example of being able to observe, to look at what it looks like, see how bad the blockage really is, see if there's evidence of hydronephrosis or something along those lines. But if it's less than 1 centimeter and there's no symptoms, usually we'll just observe the patient to make sure that things don't get worse. Now, if it's lodged in the ureter, you come down to the millimeter level, and that's what you're looking at. So if it's greater than 10 millimeters, usually we're going to do, again, some sort of shockwave lithotomy, or potentially you could do ureteral lithotomy, either open or laparoscopically, or percutaneous nephrolithotomy if it's more proximal, so closer to the kidney. That's always an option as well. If it's less than 10 millimeters, again, you can get a sense of how it just sort of depends on what's going on with the patient. But again, just sort of interesting for you to look at how these things are handled.